When we do an orthopedic evaluation, the specific verbal history is part one, and that is where we get at the mechanism of injury, or the MOI. And the MOI is really important at narrowing down our diagnostic options. And of course, it's not entirely black and white, few things in medicine are, but it can really help differentiate between what we think is going on in terms of the problem and what we don't think is going on. And the point I want to make today is that for so many people, their MOI does not suggest a structural problem, a lesion in a structure where it's lost the integrity, yet these people are getting diagnosed with structural problems. And part of that kind of paradigm is that they'll come in saying, my knee started bothering me, or my neck is getting stiff, or my back is starting to hurt. And because of the paradigm of American medicine, especially in the office of an MD, you will get a brief 10-minute evaluation. There will be incentives to do imaging from various parties, and therefore you will get an image that will likely show a structural problem, and then you're off to the races with a diagnosis of a structural problem. We know from lots and lots of studies that people with no symptoms have structural problems. And when I say structure, I mean anatomy, things you can see. We know a lot of studies show structural abnormalities in shoulders in people with no shoulder complaints, backs, knees, and a study that I hadn't seen until recently looked at asymptomatic people. They looked at their proximal hamstring attachments. So where the hamstring attaches in the bottom of the buttocks on the pelvis. They looked at over 500 hamstrings in people with no symptoms, and only 35% of those people had normal left and right hamstring insertions on imaging. So that means 65% of these people, even though they had no symptoms, had problems that you can find structurally. Tendinopathies, other types of lesions around the tendon. Basically, the radiologist is saying this isn't normal. So the MOI leading to structural problems, it becomes a problem with the imaging, especially because if you have someone who says, my thigh started hurting, my upper thigh and the back started hurting, and because of all these different incentives and problems with the typical orthopedic evaluation, you're getting an image. They're going to find something, like we know from these studies, and most people, we don't know whether or not it's related to the patient's pain, but they'll get these pictures anyway, they'll see something and they'll relate it to the pain, even though we know that we can't necessarily make that cause and effect leap between the thing we find on the imaging and the symptoms, because so many of those findings on imaging are there in people with no symptoms. So that becomes the sequence of events that becomes the actual problem. Most people's mechanism of injury is not trauma. So in those cases, it's unlikely that there is a structural integrity problem. Yes, the tendon may have some flaws on the image. Yes, the bone may have some flaws on the image. Yes, the ligament or the muscle may have some flaws on the image, but it's probably not the problem if there wasn't trauma to that structure to cause the symptoms to appear. Another reason I think we attribute so many problems to structures when they're just flawed but not problematic is because there's no paradigm for understanding another possible cause. If a patient is a jogger or a runner and, some week they just started noticing, I get this tightness in the back of my leg up where the hamstring inserts, and, it kind of just came on gradually. To me, yes, I can start to think tendon. I can also start to think, is it a mechanical problem? Because mechanical problems can absolutely occur in trauma with a traumatic episode where the joint is kind of really traumatized, but it can also come on in most cases kind of over time, more gradually, without a major inciting event or a major force that causes symptoms to occur. So if you don't understand that paradigm, you're not going to think, oh, I have this runner with proximal posterior thigh symptoms. Okay, well, I know joints can refer there, so let's think about maybe the tendon where the patient is pointing, but let's take all the pieces of the puzzle together. Other things would likely not incriminate the tendon, right? If the patient has that symptom but also has knee symptoms, then it's not tendinous probably, because then we're starting to think it's two problems, because the proximal hamstring tendon is not going to create knee problems. That's going to be, several, like 1 to 2 feet away. So we're going to start to think it could be tendon, but maybe it's mechanical. Maybe something in the hip joint's not moving well. Maybe something in the back is not moving well. We start to think about prevalence. Prevalence to me is that most people have mechanical problems in their low backs. Necessarily creating symptoms? No, but we need to see. So mechanism of injury. The main problem is we're attributing structural problems to mechanisms that probably didn't alter the integrity of someone's structures. And secondly, if you don't understand that joints can get mechanically deranged and send symptoms away from that site or create local symptoms, you're not going to have a way to explain to that person who walks in the door and says they have this pain, and you take a picture and they say, oh yeah, you have a partial tear of the hamstrings. You're not going to be able to explain to them that, well, yeah, you have a partial tear in that hamstring. However, that's present on a lot of people without symptoms. And we can move your back this way into a side glide or extension or flexion or rotation and return your hamstring strength and eliminate that pain. So it seems like it's mechanical, even if the partial tear is on the imaging. And again, there are so many data points that I'm collecting in an evaluation that would help me really discern the diagnosis. But mechanism of injury as a kind of high level understanding is really separating to me is a trauma that caused a structure to fail, a bone to break, a ligament to rupture, a tendon to avulse or a muscle to tear, or is it not? And if it's not, then those things could be present, but I'm starting more to think this could be a tweaked joint that's happened cumulatively over years, or a tendinopathy, or a degenerative process that has happened cumulatively over years due to lifestyle factors. And so addressing lifestyle factors in this case would be relevant. If the mechanism of injury suggests that this may be a structural problem, then we're less focused on lifestyle factors and more focused on kind of reversing the damage that was done by the trauma. So start to think that if it's not a major trauma as a mechanism of injury, if your knee just started hurting, if for some reason your ankle feels unstable, start to think that a strong possibility, which is not on most clinicians' mind, is that a joint is not mechanically moving well, creating local and or referred complaints.